Hi, my name is Rami Sweis. I'm a gastroenterology consultant who works at the University College Hospital on the NHS, and in the private sector I work at OneWelbeck Clinic as well as at the London Clinic. It's not uncommon for patients to present with problems with swallowing. Problems with swallowing could be up top in the throat, or in the chest, or further down below. The problems with swallowing can be a bit uncomfortable, or could be affecting the quality of life and nutrition because you're not able to get food down. What is important is to determine is whether or not there is a disorder in the esophagus that needs management urgently, or if it's a problem with the way the esophagus is working. So first and foremost, we need to perform an endoscopy because we have to look into the esophagus and consider taking biopsies and pictures. There are disorders of the esophagus that are not necessarily seen with the naked eye, and we need to take biopsies from them as well, even if it looks normal. If there is any narrowing or strictures, we need to determine if this is a condition that is serious and sinister, or if it's something that just requires some intervention, such as a dilatation or stretching, which can be performed easily in endoscopy. Biopsies that are taken from the esophagus include conditions such as eosinophilic esophagitis, which is not uncommon but under-recognized. It is like having asthma in the esophagus, and treating this is very easy and can change the quality of life of a patient. Also, other conditions that might affect the nutrition and day-to-day activities of daily living of a patient could be motility disorder, such as achalasia, whereby there's an obstruction at the bottom of the esophagus, but this obstruction is because the muscle is not relaxing. And we need to investigate this further, firstly with an endoscopy, and then with other tests, such as a barium swallow, endoflip, manometry. We can discuss manometry in a moment to define how this is used to assess motility disorders. The causes of swallowing problems could be either problems within the esophageal structure itself, the way the esophagus is shaped, the problems with the skin of the esophagus, or there could be also problems with motility, the way the esophagus functions. Each of these needs to be assessed, and this is assessed in one of three ways. The first is an endoscopy, to look with the naked eye and see what's happening in the esophagus and the lower esophageal sphincter, the valve between the esophagus and stomach. Take biopsies to look for conditions such as eosinophilic esophagitis, which is like having asthma in the esophagus, but can look normal on endoscopy. And if that's all excluded, what we can do is also perform tests to look for how the esophagus is working, look for motility disorders based on a study called manometry. This looks at the way the esophagus works and the lower esophageal sphincter to determine if there is a problem with spasm, hypercontraction, reduced motility, obstruction, and very many other conditions, that each of which have their own treatment pathway and needs to be determined in advance of considering them. Esophageal manometry is a test that looks at the way the esophagus works. We should only be doing this once we have proven with endoscopy that there is no problem in the esophagus in terms of structure and the mucosa of the esophagus is healthy. Now, once we have confirmed that there are no other diseases, manometry assesses the motility function. A tube, which you can see here, it's as thin as the inside of a pen and it's very floppy. It's got lots of sensors on it, is placed from the nose down to the stomach, and it assesses the way the esophagus works. Once the tube is in place, it goes to a computer and measures swallowing. We provide patients with water swallows and then free drinking and then a meal. And it's encouraged that if you have a culprit meal that can lead to problems that you're complaining of, to bring it with you so we can try and test it. The swallowing mechanism is assessed from the throat down to the bottom of the esophagus. And this is what it looks like. This is a healthy motility. You've got the valve at the top, which is the area right at the back of the throat, the esophagus itself, and the valve at the bottom. And we watch patients swallow live in front of us, and you could see even the patient can engage in what's happening and identify problems while they're occurring. This test is not comfortable to insert, but it is tolerated. More than 90 to 95% of patients tolerate it. I've had it done 3 times for my research. But it is important because it can subtype the problems of motility into those which are normal with hypersensitivity, to those who have obstruction at the bottom of the valve or elsewhere, or those who have hypercontraction, spasm, or hypotensive motility. Each of these disorders have their own treatment algorithm. So we can't use one definition of motility to treat all. We have to subtype and identify which disorder of motility you have and can treat it accordingly.